Good morning, everyone, and welcome to session 4 of our 2025 ACR Annual Educational Workshop. I'm Juliet Gilliam. I'm the training manager for the Arizona Cancer Registry, and thank you so much for joining us. We've got a great list of presentations for today, and I just want to go over a few housekeeping items before we get started. So first of all, we have been approved for a total of 8 CE hours. That's for all 4 sessions if you've attended all 4 weeks of this workshop. And 2.75 of those are category A CE hours. We are not approved for CEIP education. However, we do have an opportunity coming up next month for those of you who need CEIP hours, and I'll be emailing out a mass email about that upcoming CEIP opportunity shortly. So plan on joining us in December for that. Let's see what else. Here is our agenda for today. We are right in the middle of the welcome, and then we're going to hear from Jennifer Ruhl about changes to the Hematopoietic database. And I'm looking forward to finding out what is going to be new for 2026 and whenever that new HP database and manual are implemented. And then I will be talking to us about 2025 data collection changes, because we're right at the point where we should be abstracting 2025 cases. So I've got some pointers before you start abstracting for the new data collection year. And then I'm going to be talking about clarifying class of case, because we get quite a few questions about class of case. So I wanted to go through and discuss how you can most appropriately code class of case. And then we'll end with a formal Q&A session. Although if you have questions for Jennifer's presentation, we're going to do a short Q&A just for her after she's done presenting. And that way she can go and do the other things that she needs to do today. So questions for her will be after her presentation. Any other questions you have, we'll answer at the end of the workshop. We do have a chat open for you. Please use that chat for general questions and comments, for communicating with one another, and for any technical questions you might have. We do ask that you be respectful, professional, and thoughtful when you're using that chat, because everybody can see what you are posting. The Q&A chat. We do have a separate Q&A chat, and we ask that any questions you have about the presentations, you post there, because that makes it much easier for us to find them and address them during the Q&A session. So if you have related questions to the presentations, that's where we want those questions to go. And any questions we don't get to during that live Q&A session, we're going to answer in a separate Q&A document, and I will send that out following the workshop along with the certificate for your CE hours. You should have received a tracker so that you can track which sessions you actually attended. So that is almost it, but I also wanted to mention one other piece of news, which is that tomorrow is going to be the last day for our QA manager, Michelle Lenzen. So I just wanted to personally thank her for all of the incredible work that she's done during her time here at the ACR, and she's definitely going to be missed. So thank you so much, Michelle, and wishing you all the best moving forward. And with that, I am going to turn the workshop over to our first speaker, and that is Jennifer Ruhl. She's a public health analyst with the SEER program and also a member of the quality control group that focuses on education, training, and support for SEER registries. She's a team lead for the Hematopoietic and Lymphoid Neoplasm Project from 2012 to the present day. And she also chairs the NACER SSDI work group, and that's from 2016 to the present. So we are very grateful to have Jennifer here with us today to talk to us about the Hematopoietic manual and database and what we can expect as far as updates. So thank you, Jennifer. We're really excited to hear from you.
Thank you. Okay, you got it.
And we can see and hear you, so you are all set.
Thank you. I know one of the first questions I'm going to get is, when is this supposed to be posted? Well, if you're not aware, we are in a government shutdown, which means that stuff is just not getting done like it usually is. So when will the heme stuff get posted? I have no idea. I'm going to check in with our IMS folks who get all our stuff ready and have it posted and see where they are. But this government shutdown is affecting us getting out our updated manuals for 2026. Once you do get the heme manual and the updated database, you can use it for 2010 forward. But we will not be requiring any follow back with older cases due to some changes that I will be talking about. Okay, so I know some of you are like this. You hear about a heme update and you just kind of want to hide. So this cat kind of illustrates that. And for those of you who don't know me, I am a crazy cat lady and proud of it. So I have quite a few cat pictures in here just to kind of give this less seriousness, because heme is very overwhelming for a lot of registrars. And one of the main reasons for that is you don't do as many hemes as you do like breast and prostate and colon. And you don't get to know the rules and the SSDIs and all the other things as well. So Frances Ross, who was at Kentucky, told me one time, she goes, with heme, because we don't do it as much, and whenever we open the manual, it's like looking at it again for the first time. And I've heard that from other people as well. So if you struggle with heme, believe me, you are not alone. Okay, so why are we having a major update now? Well, who finally, after 2 years of it being in beta form, released the 5th edition of the hematopoietic tumors? This is the 5th edition of the Blue Book. We've been waiting on this, like I said, since 2022. There's evidence that some registrars are not following the rules correctly. And I find this out from the questions I get in. And I've gotten some really good questions that have showed where some problems are. We have general confusion about heme, which is not surprising. Evidence and instructions rules are being interpreted differently. And it happens all the time, but this past year has really shown me where some of those misinterpretations are happening, and it was time. So our last major update was 2014, so it was time. So the 5th edition for the WHO Blue Book is double the size as the 4th edition. There are now 2 volumes instead of 1. That was a lot of reading I had to do to update the database. As a reminder, if you do not have access to the WHO Blue Books, that's okay, because we will take care of that. So I was reading the WHO Blue Books and I put in information into the database that was relevant from those books. We use the WHO Blue Books and updating solid tumor rules and other resources, so we already do the work for you. But if you can get access to them, it might be beneficial for you. Hundreds of new terms added. I mean, the number of terms added just was astounding. We have some definitions updated and changed. They redid the lineage tables again. However, there are no new ICD-03 codes, so that's the good news. They're saving everything for ICD-04. Okay, so take a look at the database. So the biggest change to the database is the new terms. And as I said, there are a lot of new terms from the 5th edition. The immunophenotyping and the genetics have been updated, but only the most common are listed. It got to a point where the immunophenotyping, especially, and the genetics were like an alphabet soup. And I heard this from multiple people. And as I was reading through the WHO book, and looking at the immunophenotyping, well, about 70% have this, and 10% have this, and maybe about 3% have this. And I was like, okay, we're just going with the major ones. Otherwise, you would have an alphabet soup. So on some histologies, you're going to see a lot of immunophenotyping that is no longer there because of that very thing, cleaning it up. Abstract or notes have been updated, definitions updated, and the resource is updated. So now, if you look down the resource section, which is the very bottom of the page for each entry, it'll say the 5th edition WHO Blue Book. Some other changes were hiding the grade field for cases diagnosed 2018 forward because you don't need it anymore. So if you go in and you looking for a 2010 case, how to assign something from 2010, you found an old case, the grade field will come up, but otherwise it won't come up for cases diagnosed 2018 forward. The ICD-01 and ICD-02 fields have been hidden. We use those to help us with reportability. So for example, diffuse large B-cell lymphoma, which I know you just had a presentation on that, 9680 has not been around since ICD-01. Diffuse large B-cell lymphoma was something else, but it has been reportable since the beginning. So that's one of the reasons we use the ICD-01 codes to help with reportability. But you should not look at the heme database for reportability. And the ICD-9-CM field is hidden for cases diagnosed 2015 forward because it's no longer relevant. So we're trying to clean things up a little bit. Other changes include some same primary changes. I got a question from a central registry. They had a registrar send in 4 primaries, all of which were acute lymphoblastic leukemia. And the registrar in the central registry said, I don't think this is right. Sent me all the documentation. And I'm like, I agree with you, but let me check into it. So one of the things the SEER has is ClinCore, and these are physicians, pathologists, oncologists that are experts in their field that help us. And I have a wonderful heme pathologist. He is absolutely the best. So I sent this very issue to him, and he said ALL is always the same primary. Now, if you have an original bone marrow biopsy, one may say one version of ALL, and you have a follow-up bone marrow biopsy, and it has another version of ALL. And this is how this registrar at the hospital ended up with 4 primaries. But I want to point out that according to the rules in place, even right now, because we haven't put the updates out there, she coded it correctly based on the rules in place. So that is a major change. That's the only question I've gotten. So if you have multiple versions of ALL in your database, and you do, you might want to look and see about changing it to one primary. But as I said before, we are not requiring that for registrars to do any of those types of changes. But if you want to, you can. So what do you do when you have multiple diagnoses of ALL? What's the priority order? Well, 9812 through 9819 take priority over 9811. 9811 is the NOS code. 9812 takes priority over 9813 through 9819. That's what my heme guy told me. For the remaining combinations, you just use the first diagnosis. You do not update it. We also added to the database follicular lymphomas. Now, follicular lymphomas have always been the same primaries since 2010. And if you look at the same primaries in the database, they've always been same primaries. But registrars are still wanting to abstract 2 different follicular lymphoma primaries if you have 2 different ones. So you may be diagnosed with the grade 1, and a couple of days couple years later, you come back with a grade 3A. That is a same primary, and this is the note that has been added to the database to clarify that. So just as a reminder, the abstractor notes in the database are very important because they may have some critical information that you need. So if you have multiple diagnosis of follicular lymphoma, you do have a priority order. So if patient was first diagnosed with a grade 1, came back a couple years later with a biopsy that says grade 3A, you go back to your original diagnosis and you update that to the 3A, which would be the 9698. But you do not abstract a second primary. And we've also added a note in Rule M2 that will direct you. Mantle cell lymphoma. I started getting questions in a couple of years ago about mantle cell lymphoma in the bone marrow only. And I'm like, this is a lymphoma. Lymphomas don't originate in the bone marrow. Not really. There are some exceptions. Of course, we always have exceptions. So I talked to my heme guy about this, and he said, yes, they can. I was like, for mantle cell. And I was like, okay, nice to know. When I was reading the 5th edition, they now have a leukemic, non-nodal mantle cell lymphoma. This mantle cell lymphoma occurs in the bone marrow and the spleen. In other words, there is no involvement of any other organ or lymph nodes. Primary site for these cases is C421. Now, what about the involvement of the spleen? It's irrelevant. It makes no difference on primary site. It makes no difference on staging because if you have a lymphoma in the bone marrow, it's automatically stage 4. So if you have a mantle cell bone marrow biopsy, it says mantle cell lymphoma. If they have this leukemic non-nodal mantle cell lymphoma, then you can assign primary site C421. If it just says mantle cell lymphoma, you want to go check the imaging to see if there are any lymph nodes or organs involved first before assigning C421. Okay, so that was it for the database. Now, the database has massive changes in it because of the number of terms, the updated definitions, and so forth, but those are the major ones. The manual had pretty extensive changes, but they're not as extensive as you may fear. So we didn't add any new rules or modules, and we didn't delete any. So it's the same rules. We did an overhaul of the structure and several sections within it. And the main reason we did this is because of the questions I've been getting in and seeing the confusion and not understanding things. So when you send in questions and you're confused, that really helps me find out, okay, where are registrars really having problems? And that helps me to determine what things I need to change. So I've been collecting these issues for several years. So a lot of these issues got into the manual. We have a new section which is introducing hematopoietic neoplasms, which talks about them a little bit more and explains what they are. And this information comes from the 5th edition. So it's a little bit of background on the heme neoplasms. You don't need this section to code, but it gives you general information about them. We also have a new section for coding meta-diagnosis fields. If you were around in 2016, you will remember in 2016 that you were all of a sudden required to code the meta-diagnosis fields for lymphomas. That just freaked a lot of registrars out. And I can tell that registrars still are not able to figure out what is METS because of the primary site questions I get in. So this new section was added. And one of the things I want to point out is when the manual went out to review, so we sent it to all the SEER registries. Most of them sent back comments, a lot of comments, which is always a good thing. Overall, this was the favorite section of the heme manual. I got so many comments. Thank you for entering this. Lisa Peretti from Louisiana, she was all over that. She was just like, oh, I'm so grateful. I love this section. I can't wait to use it. Oh, this is wonderful. I mean, she was just really over the top, being so happy. So I really hope that this section will help you, especially with primary site. So in the manual, some of the things we have changed are in preparation for ICD-04. And I'll tell you a little bit about ICD-04 at the end. So the primary site assignments that were listed in the manual, like these are all the histologies that are C421, these are the histologies that are the skin sites and so forth, that has been removed from the manual because that information is in the database. The grade rules have been removed. So if you find an old case, go to the database for the grade information. So that has been removed. We have updated instructions for assigning histology based on immunophenotyping and genetics, which I'm going to go over. And of course, we have the updated lineage tables. And I've added a lot of new examples from Ask a Seer Registrar. So you can see questions that you send in to Ask a Seer Registrar, I mean, they may get repurposed for multiple reasons other than just answering your question. So the changes that have been applied for 2026 updates can be applied for 2010 forward. But as I mentioned previously, you do not have to go back and review older cases. If you want to, that's fine. Just a reminder, the meta-diagnosis fields are for 2016 forward. So that one is not, those changes are not applicable for 2010 forward. Okay. So this little cat represents a lot of registrars, and that registrars in general struggle with primary site. That is the number one. Multiple primaries is second, and that diagnostic confirmation code is 3. That has been a thorn in the registry community since it was released. So what are we going to do with these problems? Well, first we're going to look at first course of treatment. So there's been a lot of discussion among the standard setters and even among your registry community itself, getting in questions from multiple sources. We've had questions sent into NACER, we've had questions sent into MPCR, COC, SEER about first course of treatment. Now, I am talking about hematopoietic lymphoid neoplasms only. The slide does not apply to solid tumors. So I want you to be very clear about that. We are talking about heme neoplasms only. So for heme neoplasms, whether it's lymphoma or leukemia or some of your miscellaneous ones, first course in treatment includes everything up until remission is achieved. That's all first course of treatment. So if they start out with one regimen, it doesn't work, and they go to another one, that doesn't work, and they go to another one, that's all first course of treatment because remission has not been achieved. Now, let's say it takes them 2 years to get to remission. That's all first course of treatment during that 2 years. And one of the things you want to look for is that bone marrow transplant. So regardless of what they've been going through, for 1 year, 2 year, that bone marrow transplant is always going to be first course of treatment if remission has not been achieved. Diagnostic confirmation. Like I said, this is a thorn. Maybe a thorn in your side, but it's been a thorn in my side. So it has been a thorn in many, many ways. One, it's difficult for registrars to determine if immunophenotyping or genetics really is confirming the diagnosis. And that's because it is very difficult to tell. I mean, if you're struggling with that, join the club. I'm in there with you. We've also noticed that registrars are using diagnostic confirmation instructions incorrectly. Okay, so I'm a little off here. So this is about diagnostic confirmation and instructions that are currently in there on how to use code 3, diagnostic confirmation code 3. I have another slide about diagnostic confirmation code 3. So I got them confused for a second. So there's currently a section in there under diagnostic confirmation that tells you if you have genetics or immunophenotyping that confirms your diagnosis, your diagnostic confirmation is code 3, and you can update your histology to the confirmed diagnosis. So that is currently in the diagnostic confirmation section of the HEME manual. That has been removed because registrars have been using it incorrectly, and I'll show you how they've been using it. So information about coding histology with immunophenotyping or genetics is now in the histology coding instructions. So there are no histology coding instructions within the diagnostic confirmation section. I hope that made sense. I'm sure I'll hear from you if it doesn't. Now, we have submitted a request to the mid-level tactical group and the high-level strategic group, which are the entities that approve or disapprove, proposed changes. So we have to go through them for everything. So we put in a request to have diagnostic confirmation code 3 removed because, like I said, it is causing problems right and left. When I told Jim Hofferkamp about this, he was so excited. If approved, this would be a 2027 change. So why are we doing this? No one is using the data from what we can tell. Registrars find it very difficult and they're angsting over this. And registrars are using it incorrectly because they don't understand how immunophenotyping and genetics are used to determine histology. That's why we removed that section from this section in the HEME manual. So those are the main reasons that we are requesting this. Now, I put in the request, and I don't think anybody's going to vote against it. So hopefully it'll be gone in 2027. So what are the problems with diagnostic confirmation and immunophenotyping? Well, you can have positive immunophenotyping, and it doesn't necessarily mean the histology has been confirmed. For example, CD20 is positive for every B-cell lymphoma, every single one. So if you have CD20 positivity, that is not confirming your diagnosis. That is confirming you have a B-cell lymphoma. And there's a bunch of B-cell lymphomas. So that's really not telling you anything. And we cannot expect the registry community to understand, oh, this particular immunophenotyping you can't use, but this one you can. You can see that it would get very convoluted if we try to really pinpoint which immunophenotyping you can use or can't use. So if you're looking for something that's confirming a diagnosis, your genetics is by far more reliable. A lot of histologies can only be diagnosed based on positive genetic testing. And you'll see a lot of that in the AMLs where they have all these long names and these Qs and these Ts. The new preferred terminology for most of the AMLs is now very succinct. It's very short, which is nice. Any histologies that can only be diagnosed via genetic testing, they are currently always diagnostic confirmation code 3, and there's a note in the database about this, and edits will be reinforced. Now, in terms of 1 or 3, don't angst over this. If you can't tell, go with histology 1, but always, diagnostic confirmation 1. But always double check the database to see if your specific histology is always going to be a 3. But if it says it can be a 1 or 3 and you can't figure it out, default to 1. Don't angst over this. Now, if we do get approval for Diagnostic Confirmation Code 3 to be removed, the database will be updated and the edits will be updated, and you can apply it to 2010 forward. But you'll get a lot more information about that once it's approved. Transformations, chronic and acute neoplasms. So I know this was a difficult concept for a lot of registrars to understand, and in 2010, it was just mass confusion because transformations had never been done before. And I know a lot of new registrars struggle with this concept as well because you don't see it in the solid tumors. But I was very surprised when I got a question in this year from a registrar who I know has been around for 10, 15 years, maybe longer. She had a bone marrow biopsy. She had two diagnoses. One was plasma cell myeloma. The other was lymphoblastic lymphoma, I think. Now, plasma cell myeloma is an acute neoplasm. So you'll see it's an acute neoplasm in the heme database. And the two plasmacytomas, the one of bone and the one that's non-bone, they transform to the plasma cell myeloma. The lymphoplasmacytic lymphoma is a chronic lymphoma, and it transforms to DLBCL. This registrar, who, like I said, has been around for 10 or 15 years at least, figured that Rule M10, I think it was M10, applied, and this was one primary because you had a chronic neoplasm, which was the lymphoplasmacytic lymphoma, and an acute neoplasm, which was the plasma cell myeloma. So overall, this was a plasma cell myeloma. When I saw that question, I just about lost it. I was like, no, 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 that is not how these rules work. So I was like, okay, obviously there is a misunderstanding. And if one registrar sees it that way, there's going to be others that see it that way. So this was a real eye-opener to there are some problems here. Now, the beauty of this question, I was very nice in my response to the registrar. And you actually will see my response to the registrar because this example was included in the heme manual. It was a perfect illustration of interpreting the rules incorrectly. And I included a lot of questions and my responses verbatim in the manual because I was like I said, if one is thinking this way, there's others as well. So I'm hoping by including some of those questions that show you where some of the problems are will help you, learn the rules better or understand them better. So this was an excellent teaching question. And the answer was it was two primaries, actually. It was M15 was the applicable rule on that one. We have a new section on the hematopoietic database, and this section goes through the entire database and explains every single field and what it's used for. You do not need it to code cases, but if you're new and you're really struggling with the database, this is going to be a wonderful section for you to look at because it explains each field and what it is used for. And the steps for using the heme database and heme manual, this section got a pretty significant overhaul. Always start with the database. Always, always, always. There are no exceptions. Now, if you were around in 2010 or 2009 when Carol Johnson and Steve Peace were doing all the training, Carol Johnson said start with the manual. That got changed in 2012. But we still have registrars, not necessarily registrars that have been around since 2009, still have registrars that are starting with the manual. That is wrong. Always start with the database. Identify your working histology or multiple histologies. So I included a screenshot for how to search for alternate names as well. Once your histology or histologies are determined, then move to the heme manual. But there are going to be some instances where the heme database answers your question and you don't need the manual. Now, if you have a multiple primary, you're going to have to go over into the manual. But just keep in mind that sometimes the database is all you need. So always start with the database. So as I said, this was a major update. It added screenshots from the database to help direct registrars, added roadmaps to the multiple primary rules and primary site histology rules to help you move along more quickly. So here's your roadmap for the multiple primary rules. So this is not replacing going through the multiple primary rules. If you've never been through the multiple primary rules, you need to go through and read them and familiarize yourself with them. But if you have a general knowledge of them, you don't memorize them, but if you have a general working knowledge of them, this will help you find, oh, I need to go to M7 based on the scenario I have, or I need to go to M13 or M4 based on the scenario I have. And it just helps direct you more quickly to what you need. And done the same with the pH rules. These are not replacing the rules. This is just a roadmap to get you to the appropriate section more quickly. But you still have to go look at the rules. And as I said, if you're haven't read through the multiple primary rules or the pH rules, you need to read through those a couple times to familiarize yourself with them before you start depending on these roadmaps. Multiple primaries calculator. This calculator drives me nuts. This registers, I mean, some of the questions I get in on this, I mean, it increases my stress level. But never, 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 never start with the multiple primaries calculator to determine if you have a multiple primary. I've been saying this for years, and registrars are still doing it. Rule M15, which tells you to go use the multiple primaries calculator in the heme database, is not a default rule. And that's how some registrars are using it. It's a rule of last resort. You are to start with the database first and then work through the heme manual. That is how you go through the rules. Now, some registrars are doing that, but they are missing the applicable rule because they're not paying attention. That's another reason I made the roadmaps to, help registrars focus on those rules because they're difficult to get through, especially if you're new or you're not seeing many of these. Read the rules carefully. Like I said, the roadmaps hopefully will help you find the applicable rule. Now, there are situations where M15 is the appropriate rule, but registrars are using it, much more than they should be. And do not compare the number of primaries you get from the multiple primaries calculator to what is determined in the manual. I get questions about that all the time, and I'm like, why are you doing this? You may end up with different answers. The rules take priority. If you have a rule that tells you what to do, don't go to the multiple primaries calculator because it's not applicable unless M15 is the rule. Then you go there. Only use the multiple primaries calculator when the manual instructs you to do so. So one of the things I've done is I've added in the multiple primaries calculator section, this was expanded, multiple examples of when M15 applies and multiple examples of when M15 doesn't apply and why it doesn't. Once again, this is how you apply this rule. So when I've added different things in, it's to show you the application. So you can read the rule, but one of the reasons these changes were put in is to show you how to apply the rule. So hopefully this will make things clearer. Okay, I'm getting short on time here. M8 through M13, which are the multiple primary rules for the chronic and the acute. The 21 days and simultaneously have been removed. I can't tell you how many questions I got in. What if it's 22 days? What if it's 24 days? What does simultaneously mean? I honestly got these questions in. So short headers have been added to all the M and PH rules, which will hopefully help registrars to get to where they need to be. So, for example, Rule M5, Hodgkin and non-Hodgkin B-cell lymphoma in the same biopsy specimen. So that is Rule M5, which currently says simultaneously occur. So the simultaneously has been removed. Now, if you're familiar with the changes that went to the SSDI manual and the EOD and summary stage manuals last year with the headers, now the heme has the headers as well. So believe me, you'll notice it. You'll notice the changes. One of the things that has been added in terms of rules M8 through M13 is the initial clinical workup. Now, all of you know what the initial clinical workup is, especially if you do AJCC staging, because that's your clinical staging information. Now, clinical staging is not really relevant to heme neoplasms. Lymphoma is always going to be clinical because they just do not do pathological staging anymore because imaging has gotten so good. But the initial clinical workup concept does apply. So this is the time frame of when patients are first diagnosed. The initial clinical workup may include blood work, imaging, biopsies, which may or may not include the bone marrow, immunophenotyping, and genetic testing. Now you need to remember in some cases that treatment may be started prior to them finishing the clinical workup. So as I said, this has replaced the 21 days and simultaneously. And I got several comments back saying this really helps. We really like this. So hopefully it will be helpful to you. Okay, so a couple years ago, my colleague Lois Dickey, actually this might have been more like 10 or 15 years ago, came up with the hematopoietic primary site rules. I really wish we could adopt this because it would make things so much easier for us. And I just thought this was really cute, so I added it. Under the primary site coding instructions, have added some additional information about spleen involvement. If you have spleen involvement, unless you have one of the splenic lymphomas or possibly DLBCL, spleen does not factor into primary site. The blood is filtrated through the spleen, so you have blood and you have cancerous cells going through the blood, so they just go through the spleen. So the spleen becomes the lymphoma, the leukemia gets into the spleen. That doesn't mean that it's the primary site. It is very rare for the spleen to be the primary site, except for these two lymphomas. Bone marrow involvement. If only the bone marrow is involved, code primary site to bone marrow. There are no exceptions for this. But remember, the bone marrow is involved. The spleen may also be involved, but the spleen does not factor into primary site. It would be bone marrow. If the bone marrow is involved and other organs and or lymph nodes are involved, the bone marrow involvement is recorded in stage, and this is always the stage 4. So I had one register that ended up at, I think it's pH 27, assigned C809, because there were two organs involved. One was like the colon and the other one was the bone marrow. And I was like, bone marrow is not considered an organ in this type of situation. So we expanded information about that rule. So registrars struggle with primary site because they don't recognize the common metastatic sites for lymphomas, which incidentally are also the most common sites for solid tumors, except for the bone marrow. So for years, registrars have been taught solid tumors and hematopoietic are very different, and they are. But the lymphomas and the solid tumors do have something in common, and that is the most common metastatic sites. So bone, brain, liver, and lung. Just like these are common metastatic sites in the solid tumors, they're common metastatic sites with lymphomas. But they can also be primary sites just like they can in the solid tumors. Makes things a little difficult. Distant lymph nodes, you may have that, but the most common metastatic site for lymphomas is the bone marrow. So if you have lymph nodes or organs involved and the bone marrow does not factor into primary site, it factors into stage. So for hematopoietic neoplasms where primary site C421, all the metadiagnosis fields are coded to 8. And it applies to your leukemias, your MTS, and your MPN. These are always going to be C421, and that information is included in the database. And it also applies to lymphomas where the primary site is C421. But remember, if you have a bone marrow biopsy that has a lymphoma, the diagnosis is a lymphoma, do not assign primary site as bone marrow unless imaging proves there is no other involvement. Be very careful using that C421 for lymphomas. You have to go look at the imaging. Just a reminder to see the SEER or the STORE manual for the complete instructions for coding the metadiagnosis data items. Okay, so we have a new section in the manual about coding the metadiagnosis fields. And this is the section that a lot of the reviewers really liked. So when you find yourself with a lymphoma case, and this is going to apply to the late stage lymphomas, sometimes stage 3, but mostly stage 4 lymphomas. If any of the common metastatic sites are involved, which are listed there, set those aside and work with the remaining sites' lymph nodes that are involved and see what you come up with. So you're probably thinking, what is she talking about? Okay, I have an example, of course. CT abdomen, pelvis, large mass in cecum, multiple regional lymph nodes involved, right hemicolectomy, DLBCL, PET-CT, nodal mets above and below the diaphragm, skeletal mets, bone marrow positive for DLBCL. So the question that came in was, what is the primary site? First, you determine what is probably metastatic. Notice the word probably. So we have bone, the skeletal mets, the bone marrow, and the lymph nodes. So we have lymph nodes above and below the diaphragm. So if you have an organ as a primary site, some of those lymph nodes are probably going to be distant lymph nodes. So we've set those sites of involvement aside. So let's look at what we have left. That leaves us with the colon and regional lymph nodes. So our primary site is the cecum, which is the large mass in the cecum. Our primary site is the cecum. And our metadiagnosis data items are bone is coded to 1, distant lymph nodes is coded to 1, and metadiagnosis other is coded to 1 for the bone marrow and the other metadiagnosis fields are 0. So when I talk about setting aside the involvement of the most common metastatic sites, this example, which is also in the manual, is what I am talking about. And I think you will find that this will help you with primary site in those late stage lymphomas. At least I hope it helps you. Histology and ambiguous terminology. I gave a presentation. I don't remember where it was. Oh, it's when Juliet and I and Jim Hofferkamp did the NASER webinars on heme. And I talked about consistent with is now considered definitive diagnosis. So I was putting this in the manual. And then I got a message from Jim Hofferkamp, who was also working with Denise Harrison, Allison Van Dyke from SEER, and a few others on the solid tumor rules. These terms listed here are now to be used as definitive diagnosis for coding histology only for heme neoplasms and solid tumors. So when the solid tumor rules update comes out, and once again, same problem with the government shutdown, don't know when it's coming out, you will see this information in the solid tumor rules. So this is something that you need to look for. So if you see consistent with, that is a definitive diagnosis. Probable is now a definitive diagnosis. And they have worked with physicians over the past couple of months. And these are the terms that the physicians agreed could be used as definitive diagnosis. Once again, this applies to the solid tumors and the hemes. Okay, histology coding instructions. Registers are not to update the histology based on genetics or immunophenotyping without a pathologist physician statement. Okay, what's Jennifer talking about? So as you know, in the final diagnosis or the synoptic report, the pathologist is always going to put the final diagnosis. In another section, they may put the positive immunophenotyping or the positive genetics. And what is happening is this. So this is a question I got in. So we have positive RUNX1, positive MPN1, and positive FLT3. So the register is asking, which histology do I assign? Of the three, these three listed here are unique ICD-03 codes for AML. So the question was, which one do I use? None of them. Because the pathologist diagnosis is acute myeloid leukemia with monocytic differentiation. Based and no revised diagnosis was available. You have to go with the pathologist diagnosis. You cannot update the histology based on positive genetics. Now, if you are able and you see something that comes in as positive for genetics, but there's no addendum to the diagnosis, if you can go talk to the pathologist or the medical oncologist to get a verification, then by all means do that and then update your histology. But as a registrar, you do not update the histology. It has to come from the pathologist or the managing physician. Now, another thing I want to add, I had a very similar question like this, except the physician stated RNX1 positive, MPN1 positive, and FLT3 positive. So very different from this diagnosis. So we have 3 AML codes. Same question, which histology code do I use? It is possible, so I had to go to my heme guy for this. According to him, it is possible to have multiple positive genetics that point to multiple AML codes. You're going to see this mostly with AML. They do not have any combination codes, and they do not have any priority instructions. Which AML code takes priority? So if you have multiple positive genetics and the physician has said, oh, AML with positive, 1, 2, or 3, you have to go with 9861/3, which is AML NOS. Because like I said, there are no combination codes and there's no priority at this time. So I know some of you are just scratching your head going, I don't understand a single thing. And I'm with you. This can be very confusing. So it would simplify our lives if we went back to 9590, which is lymphoma NOS, and 9800, which is leukemia NOS. How easy our jobs would be. But then again, we might get bored. Okay. pH rules. No major changes to the pH rules. Many links have been added throughout the pH rules to help you navigate the manual. You also have links to the lineage tables. So why do you have links to the lineage tables? Well, if you're looking at an NOS code and a more specific code, knowing which lineage tables they belong to may help you determine if you have a single primary or a multiple primary. The lineage tables, you are not required to use them, and you don't need them to determine if you have a single or multiple primary. But if you familiarize yourself with them, they may come in handy. But they're there if you want to look at them. We do have one minor change to Module 4, 9727, which is this diagnosis is now its own lineage table. It used to be an AML. This is the third time they have changed this histology. Who knows if they'll change it again in 6. pH rules, once again, multiple examples are added. Examples added of when a specific rule is not applicable have also been added. Because what I'm trying to do when I do that is to show you how to apply the rule and how not to apply the rule. Because the application is the problem that many registrars are having. Added clarification that C779 does not apply when there are no lymph nodes involved. Yes, I got a question and there were 2 organs involved, and the registrar said, can I use C779? And I'm going, no, you have no lymph nodes involved. That was the C809. And we are to C809. So this has been updated to include additional information so that hopefully you won't end up at this rule. Because when I was working with Juliet and Jim on the NACER webinars, Juliet said, we have a number of cases that are coming in assigned as C809 where there is a known primary site. So this is a problem. I did not find that surprising. So C809 is when you have multiple organs involved and there is no lymph node involvement. So no lymph node involvement. That's key. So if you have lymph node involvement, you need to go back up to around 21, pH 21. Multiple organs does not apply to bone marrow, spleen, and common metastatic sites. Because remember, you want to filter out your common metastatic sites when you're trying to determine primary site. So this is unknown where the lymphoma originated and there's no lymph node involvement, and the physician doesn't document the site of origin. So alluded to the lineage tables, once again, you don't need them to code, but you may find them interesting. Okay, so all of you are going to go into one of these categories. You're lost. This little tuxedo looks completely lost. Then this other cat doesn't look too hard, but time will tell. I need to see the updated manual. I know some of you are chomping at the bit for that manual. And the last cat here is like, oh, this is a piece of cake. We can do this. So, which cat are you? I'm betting that a lot of you are lost just because of the nature of heme neoplasms. They are very, very difficult. Now, here are my cats. So my crew and I are ready to answer any questions you may have. And if you're anything like the other two state associations that I presented this to, nobody really had any questions because they just, I guess, found it overwhelming or need to think about it. But the true test is going to come when you start using the manual, which I'm going to check on the status of that after this call. So, do we have any questions?
We do actually have a couple of questions for you.
Oh, good.
So the first question I see is, what would be considered second course of treatment for these heme primaries if everything up until the bone marrow transplant is considered first course? Is there still a place to consider a treatment failure? And if this is your question, feel free to clarify if I'm not stating it well enough. But what would second course treatment for heme primaries look like, basically?
So they have achieved a remission, and then the cancer comes back, the leukemia comes back, or the lymphoma comes back. And when that happens, then anything at that point is second course. You may actually see this with your chronic and acute neoplasms, like follicular lymphoma. They go in, they're diagnosed with follicular lymphoma, they're treated, and everything looks good. And 2 years later, they come back and they're diagnosed. Well, that's second primary. Never mind. I'm getting myself confused. You can see why heme is complicated. But yes, the patient has to go into remission, but then the cancer comes back.
Okay, so even treatment failure where the oncologist is saying they didn't respond or they didn't have what I a lot of times will see is they didn't have a good enough response to the first regimen they put them on. So they're switching to a different chemo regimen. That would still be first course treatment.
That is still first course treatment.
Okay, thank you. I know that sometimes gets really tricky as well.
Now, there are also some clarifications on that for solid tumors, for the solid tumors. And you'll find that in the STOR manual and the SEER manual, which have been released. I know the SEER manual's been released. Okay,
I am definitely
next.
looking forward to digging into 2026 store changes shortly.
Okay, any other questions, Juliet?
Yes. So the next one is also about this first course treatment. And I'm assuming that's again referring to everything up until the bone marrow transplant. Does that apply for 2026 forward, or should we be applying that to older cases as well? When did that change?
Uh, that's a tough question to answer. Now, apparently, this is how we should have been coding treatment all along. We used the word apparently. Um, I would go ahead and use this rule for cases diagnosed 2010 forward. So if you find any older cases, go ahead and apply this rule. This may be a situation where it might be a good idea to go back and check on some of those older cases where a second course of treatment was done and shouldn't have been done. But like I said, we are not requiring you to go back.
That makes sense. And of course, for us, since we're not a SEER state, we want to make sure everyone is careful to check not only what STOR has to say about first versus second course, but also we have our Arizona Cancer Registry supplements where we give you some clarifications as well. So make sure that you're looking there as you're trying to determine all of these questions.
Now, my memory is because I was working with COC, Claudia Bird and Dolores Atkins and Cindy Richardson. So those are three of the COC folks. And we discussed this quite a bit. Now, I believe in the store manual and the SEER manual that they have referred you to the HEME manual for the specific instructions for HEME.
That sounds right.
Yeah, regarding first course of treatment. But as I said, there have been changes for the solid tumors.
Okay, so we need to definitely make sure that we take a look at that when the new solid tumor manual updates come out as
And the
well.
solid tumor rules, the solid tumor changes are year specific. That was a
is
call
good.
from, that's from COC.
All right, thank you for clarifying that. I have one more question from our group, and that is, what are the genetic tests that would be considered confirmatory? And I'm assuming this is confirmatory of a specific histology. And are those tests available in the revised abstract or notes so that we know which ones we can consider definitive for determining histology?
The most common genetic testing are included in the HEME database. The problem with the immunophenotyping and the genetics is they are constantly finding other things that confirm a diagnosis. And you also have, uncommon ones that may confirm. So, when I was reading the blue book, it said for some of them, it's like, oh, this is positive in 3% of the cases. Well, leukemias lymphomas are already rare, and then you're talking about 3% of the cases. If you think that the immunophenotyping and genetics right now with the current database, there's a lot of them. I mean, that would have been doubled if I included absolutely everything. But the key with the genetics and immunophenotyping is the pathologist statement. What are they determining to be the final diagnosis? Once again, the registrar cannot update the histology based on genetics or immunophenotyping. It must be done by the pathologist or the managing physician.
And hopefully we have some really good pathologists and oncologists who are helping us out with that.
Yes. I don't know how often they're doing it or not doing it. A lot of what I interpret is based on questions that come into me. So if you're finding, anything that you see in the HEME manual, if you're seeing something that's just so contradictory happening with your pathology reports, let us know. Because then, that's how we know where problems are arising. So,
Absolutely. You have to know where people's thought processes are.
yes, absolutely. So, even though I had some of these questions that made me kind of freak out, because I was like, oh my gosh, they were really good questions because it really helped me get the pulse on what is going on and what registrars are thinking. So even if you think your question may, I may, think, what are they thinking? I'm not going to respond that way, of course, because that's not very nice, but it's just an initial reaction. But they actually are very helpful to help me understand where you are having problems. Because like I said, if you were having problems, there's somebody else. You are not alone.
Very true. Well, thank you. Those are all the questions that I see. But of course, if you all have other questions that come up as you start looking at these changes, just email them to me and I can pass them along as well, based on this presentation. I know that we don't have the slides available for you yet, but hopefully Jennifer will be able to get them to me at some point soon. So I will send them out when I get them.
Just as a heads up, with the government shutdown, ask us your registrar questions are not being answered. So you can't send anything to there right now either.
Makes sense. Well, thank you again for your time. We really appreciate it and appreciate you and all the work that you do on these manuals.
Well, I really hope these changes that were incorporated are helpful. So even feedback of, oh, this really helps. Oh, this clarifies a problem I've had. Oh, this answers about 20 questions I've had. Anything that gives me any indication of if this helps is needed, because I can make changes all day long, based on questions I get in, but that's a very small number of questions compared to what is actually going on in field. So, you know, if my updates don't make any sense or my updates make perfect sense, I like to know either way.
Absolutely.
Well, I will turn it over to y'all for the remainder of your workshop.
Thank you again. I'll just go ahead and switch over to our next presentation.
Bye.
Bye, Jennifer. Thank you again. All right, let's switch gears a little bit and move back from 2026 and the HEME changes to 2025 and what's going on with changes that affect us with the current coding year. So hopefully everyone can hear me and you should be able to see the title slide for my presentation. Sounds like we are good to go there. So I will get started talking about upcoming changes for this year. So my objectives here are to explain data collection changes applicable to 2025 cases, to describe the appropriate references that you are to be using when you're coding 2025 cases, and to give you some information about ACR required site-specific data items for 2025. So let's dive in. I want to start by talking about 2025 coding manuals, because we have made some changes to our ACR coding manual that you have likely noticed if you have had a chance to take a look at it. And so I want to make sure that we're all on the same page and aware of what is new and different. So let's start by talking in general about what manuals you are to be using. And I will go over that really quickly. We did send that out, and it's also uploaded onto our ACR website, where you can find the 2025 ACR manual. So you can get this list there as well. AJCC 8th edition still applies. We don't collect AJCC here in Arizona. However, if you are required to do AJCC staging for other reasons, if you're a COC facility, or if you have another requirement that would apply where you're coding AJCC stage, then you need to be making sure that you're using the correct manual to do that. And there have been a number of sites, I've got them listed on the slide, that have been updated to 9th edition, and the years are available when those 9th edition chapters came into play. So if a site has already been updated to the 9th edition module, then you would use that 9th edition module. If it hasn't already been updated, then 8th edition still applies. But I don't want to spend too much more time on AJCC, because as I said, we do not require it here in Arizona. Site-specific data item and grade manuals. The latest that I could see is version 3.2. They do give you a change log. I always find it helpful when these new manuals come out to look at the change log and see exactly what has been updated. And so I've got the links for you there. You'll use the most up-to-date version of those manuals. And like I said, I find it really helpful when I'm considering what I need to update in our ACR manual to look at that change log and see what changes overall are going to apply. And it's good to do that at the beginning of every coding year, to just take a step back and remind yourself of what's changed. Because I know we do presentations like this where I talk about updates and changes, and then you actually get to coding those cases. And I still have to remind myself when I start abstracting what I need to be looking at. because there's too much. It's too much for us to keep in our heads. You have to go to the right place and the right version of the manual and make sure that you're coding accurately. So, okay, summary stage manual. There's a link to it there. You want to be using the latest updates to the summary stage manual. They do have rolling updates, so be careful and make sure that you are availing yourself of the most recent updated version unless indicated otherwise. But for most of these manuals, it's going to be the most updated version. ICDO, there were no new ICD-0 3.2 updates for 2025 cases. As Jennifer mentioned in her presentation, everything is gearing up for ICD-04. We still don't know exactly when ICD-04 is going to be released and applicable. Maybe 2028, maybe past that, we don't know. And we don't know how all of these shutdowns are going to impact how quickly ICD-04 is going to progress through the various levels of approvals. So for right now, we are still using ICD-03 plus the most updated versions of those ICD-0 3.2 tables that come out every year. But for 2025, no changes there. And I've given you a link to where you can find those updates. You need to be familiarizing yourself with ICD-0 3.2 and those tables. There's usually a table that's organized numerically by histology code. There's also an alphabetical table that gives you the same information, just organized a little bit differently. And that will tell you all of the similar terms and synonyms and what the preferred term is as well. The STOR manual gets updated every year. STOR 2025 is effective for cases diagnosed January 1st, 2025 and later. And they've started to include the CTR guide to coding radiation. It used to be separate, but for the last couple of years, they have incorporated it as an appendix in STOR. So you're going to want to make sure that you are looking at that appendix when you're coding radiation fields. You can find the STOR manual on its own, but we use the STOR manual with permission as the basis for our ACR manual. So you're going to want to look at the ACR manual because that has the 2025 STOR manual and the ACR supplements and ACR notes that we always give you to clarify our state-specific instructions. The HP database and manual, I'm not going to spend too much time there because Jennifer just did a great job explaining where that manual is going. We don't know when the new manual or database is going to be uploaded, but I'm sure that we'll receive information as that comes out and as we're able to start using it. So current manual and database still apply until we are told otherwise. CRRX, same as normal. I've given you a link and I send this out every year so that you know where to go and grab the latest changes. But like I said, changes in our field happen quickly. They do rolling updates. So as soon as I put something like this out, then they come out with a rolling update. So just make sure that you are looking where you need to make sure that you're using the most up-to-date version of all of the manuals. The ACR handbook has been updated for 2025, and that, as I mentioned, includes the 2025 STOR plus the ACR supplements, and that's changed significantly. So I'm going to take a little bit of time later in this presentation to show you the new look because I'm very excited at how that turned out. We usually release this manual in the late spring because we want to make sure that the latest version of STOR and the applicable updates documents is available before I start working on those changes. So I'm already going to turn around and start focusing on 2026. But I wanted to make sure, since I know some hospitals are just starting now to look at 2025 data collection, that you guys have some information to get you started. And I always send out an email when the new version of the ACR manual is available on our webpage. So if you are not on my distribution list, make sure that you let me know that you're not getting those updates emails from the ACR, and I will make sure that you are added with your preferred email address so that you receive our communications. Because we want you to have all the information that you need to make your lives as easy as we can in the middle of all the data items that we have to collect. So I've given you the link to our ACR handbook. Make sure that you are looking at that, because those ACR supplements give you state-specific instructions that you need to be following. And I know some of you may abstract for a variety of states, but when you're coding cases for Arizona, those are the expectations we have, that you are going to be familiarizing yourself with our ACR specific supplements as well, and that you're going to be coding cases and submitting cases that are coded according to our ACR instructions. Let's see, did I skip anything? Oh, solid tumor rules, same deal. I've given you the latest updates that I could find, but they could have changed. So go to the links that I've given you, and that should take you to the most recent version of all of these manuals for your use. And there's a revision history as well. I always appreciate that, to let me know upfront what the changes are. So, okay, here's a picture of our website. Where do you get all of the 2025 documents? Well, you go to our ACR website, and you will see on the sidebar under Cancer Registrar Resources that there is a tab for the Arizona Cancer Registry Coding Handbook. That's where you're going to go, and you'll see that we always have the ACR Coding Handbook first. And as I mentioned, just below the link, it includes STORE and our ACR supplement, which has been updated for 2025. All of these other documents, you're going to notice we have a couple of new appendices this year, and I'll go through what those are briefly a little later on in this presentation. But everything that you need is available on our website. You've got a summary of changes, so you know what we've updated. You've got the most up-to-date recommended abbreviations. You've got race and nationality descriptions. And notes I'm not going to talk about too extensively now, because I want to highlight that in just a few minutes. And there's another new appendix, required data items for hospital abstractors, that I think you're going to find useful, but I'll show you that in a little bit as well, and tell you what the difference is between that appendix and the appendix that you're used to, which is the ACR required data items for 2025. And then we also give you, as we usually do, a list of what SSDIs are required for Arizona. So make sure that's where you're going to make sure that you are completing your cases by providing us with the required site-specific data items. And then the texting tables. We released that a couple of years back. It gives you our minimum texting requirements for all of the text fields that we collect. And we are holding you to those texting standards. If we say that that's the minimum requirement, your case is not complete if you are not at least giving us the minimum amount of text. And if you think about it, it makes sense. We get cases, the same case from a number of different hospitals, and all we have is what you send us. We don't have access to the medical record in the way that you guys do. So that text is important, because we have to be able to QA and evaluate what you've coded based on the text you give us, because that's what we have to go by. So make sure that you are using these resources from our website when you're coding your cases. Okay, AJCC 9th edition updates. I'm not going to say a lot about this, but there are 4 new sites that have gotten AJCC 9 version 9 modules, and they're listed on the slide. So as I said, we don't require AJCC staging, but it gets transmitted to us if you code it. So make sure that you're using the appropriate staging schema if you are required to do AJCC staging. All right, as I mentioned, the 2025 ACR manual has a new look. We got some branding updates here at the state, so we updated the look of our manual as well. You're used to seeing a bunch of ACR notes on the actual pages themselves. This time around, you will not see those on the actual page, because we have pulled them out and we have made them into a separate appendix, Appendix F, has all of the endnotes. So what you're going to see when you look at the pages is you're going to see a box at the top that tells you something like this page, which is ACR Gen 014, and that 14 is the page number that this happens to be from in store. And you can click on that, and that will take you directly to the endnote that applies for that page. So for instance, you will see that we have a couple of notes, and on the actual page, what I did is I highlighted where on the page those notes apply to, and there's a link there. So if you click on the highlight, that will also take you to the appropriate page in our endnotes appendix. So you can click on that box at the top of the page, you can click on the highlight, and then you'll see that that same number from the top of the page is represented on the endnote page so that you can figure out what page those endnotes apply to. And when you go to the endnotes, you'll see the first thing in each of the endnotes is the phrase that was highlighted. So case eligibility is highlighted. You click on that highlight, or you click on the box with the note number, and it'll take you to that endnote. The endnote that applies to case eligibility is see additional ACR case eligibility information. The reportability section starts on page 1 of the ACR supplement. So that's a reminder that we have some specific reportability instructions that apply specifically related to what we require in Arizona as reportable. So same kind of notes that you're used to, they're just in a different place. So hopefully that all makes sense. The other new appendix I mentioned is Appendix G. These are a list of exactly which data items you are required to directly code or text. Now, we've always provided you a list of what fields are required, but that list also includes derived fields that you don't actually touch when you're abstracting. And it also includes fields that we derive here at the ACR and we code here at the ACR as well. So if you want the complete list of every field that we end up requiring, you can go to that list. It's available for you just like it always has. If you want a quick place to look to see what fields you have to text or code to consider your abstract complete, that's what this is for. And I've got that note on the top of the page about what the difference is as well. And this will be updated every year. It includes site-specific data items that you have to code. It includes text fields. It includes coded fields. So hopefully that makes sense. I've also indicated here what is new for 2025. So for 2025, we have 2 new site-specific data items that are required for cases submitted here to the ACR. So you'll know immediately this is a new data item that you now have to code or text, although there are no new text fields for this year, but if they add them, they would be listed as well. Any text fields are highlighted for you in a different color as well. So if you look at 310 and 320, those are the NACER data item numbers. Those are both text fields. So if you're wondering, what do I have to code? What do I have to text? If it's highlighted in this color, in this turquoise, those are text fields. I've also given you some specific notes in orange as well that show you which primary sites those codes might be applicable for. So there's a lot of information here. We've tried to make it as comprehensive and comprehensible as we can, but it is a new look. It is going to take a little getting used to, and spend time getting familiar with it. And if you have feedback, I'm happy to hear that feedback. Let me know if there's something else that we should add to help you. And hopefully you're going to like the new changes. It looks much less cluttered, and I'm excited that you now get to start using it. Well, if you were already coding 2025, you should have been already, but I'm excited to be able to highlight those changes for you. All right, so what is new for 2025? We have those 2 new site-specific data items that I mentioned, and we have a bunch of new data items that we are not requiring. So if you look at the left-hand side of the slide, Those are the new ACR required data items. There are only 2 of them. And then look at all the other new data items that we chose not to require. Those are on the right. And those are mostly related to the pediatric staging schemas, and those are not going to be required for 2025. So how do we determine if the ACR is going to require a new data item? Well, is it required by the CDC or NPCR? Or is there another logical reason why we want to require that data item? And usually if that's the case, we've got a good explanation in the ACR supplements for you, and there's a reason. So either it's required by the CDC or NPCR, or we have a logical reason why we might be requiring it. There were a number of retired data items in 2025. Those were basically derived data items and not anything that we are used to directly coding, so I'm not highlighting that for you. But if you want specifics about what was retired in 2025, you can look at the 2025 updates document on the ACR website, and that will go through with you what those retired data items were. So let's talk about those data items that we are going to start requiring with 2025 cases. So the 2 are PDL1, and that is a new lung data item, and that applies 2025 forward. So I believe you should be getting an edit if you try to code that for a pre-2025 case, and I'm sure Michelle will let me know if that's not the case. But 2025 forward, lung cases are going to require you to code PDL1, and the description of how you code that is going to be in the site-specific data item manual. The other new data item is this post-transplant lymphoproliferative disorder. And this isn't a completely new concept, but we now have a site-specific data item to capture it. And it applies to specific histologies that I mentioned on my slide. So it'll apply to lymphomas, including CLL, SLL, plasma cell disorders, plasma cell myeloma, and primary cutaneous lymphoma. So it should show up, if you code the histology correctly, in the site-specific data items you're supposed to code for those cases. So you should see it if it's applicable. So post-transplant lymphoproliferative disorders used to be reportable as 9971/3 if that was the only diagnosis. And in 2021, there was a change based on the release of the 4th edition WHO Hematopoietic Blue Book. So WHO changes end up driving changes to how we code things. It's true now, a lot of what Jennifer mentioned had to do with the 5th edition WHO changes to heme cases. Well, in 2021, there was a change, and the histology for post-transplant lymphoproliferative disorder was changed to a /1 behavior code and only reportable for brain cases. What's going on in 2025? Well, if post-transplant lymphoproliferative disorder is the only diagnosis, the behavior code is going to be /3, and it is going to be reportable. And this new data item will apply. So look at the updates document for more specifics. Look at the SSDI manual for more specifics. I just wanted to highlight this is a new change for this year. Okay. They changed a small statement in the first course of treatment section of STORE on page 27. So I wanted to highlight that for you. The intent of this presentation is not to exhaustively go through every single change that happened in 2025. I'm just highlighting the changes that I think are important for you to keep in mind as you start coding these cases. So what is the change? I've got it highlighted in yellow. If the first course of treatment plan changes due to an improvement in the tumor burden, the added treatment would still be considered a first course. So An example of that would be palliative chemotherapy or radiation is recommended and administered per the first course of treatment plan. Initially, a resection of the primary tumor was contraindicated due to the tumor size and the location. But follow-up imaging shows an improvement in the tumor burden, and the treatment plan was changed because the tumor became resectable. So they added surgery to the first course of treatment plan. Well, that would be an example of an added treatment based on an improvement of tumor burden. That surgery is going to be first course, even though that resection was not noted in the original first course of treatment plan. There isn't any progression of tumor. This is a case where that patient became resectable. So a little change, but it's an important concept. Next slide. There are a number of fields where we at the ACR do not allow you to submit blank. That is why we are very specific in the ACR supplements about how you can estimate. So make sure that you are looking at what we've provided you in those supplements and estimating appropriately. Date of initial diagnosis, that cannot be completely blank. Date of first contact. In fact, you should know the date of first contact. If you diagnose that patient, that date of first contact is going to be the date of diagnosis. If you didn't diagnose them, but you started treating them, that date of first contact should be the date that you started treating that patient. If it's a non-analytic class of case, and we're going to talk about that more in the next presentation, that should be the date that that patient became a non-analytic case for your facility. So that should not be completely unknown or blank. Social Security number should not be blank. We have specific instructions on how you need to code that if the complete Social Security number is not available to you. So I've given you the list. Another big one that I did a project on this past year was that abstracted by field. We had a lot of cases where either the abstracted by field was blank or it was an inappropriate value. So we assign you a 3-digit numeric ID to abstract cases here in Arizona. And I pulled a list of all the times where the abstractor ID was something other than a 3-digit numeric code, including initials, including being a 2-digit code. So if you do not know what your abstractor ID number is, or if you have not been assigned one, you need to let me know that, because we're going to continue to monitor that. We need to know who completed the abstract so that we can communicate effectively when that is necessary to communicate back with you about your abstract. So make sure that you're using your 3-digit numeric ID. All right, stepping down from that soapbox, but here's a list. Please do not submit those cases with blanks, because that is not valid for these fields that I've listed here on the slides. And again, if you take one thing away from this presentation, make sure that you are also using the supplements and the additional information there, including how to estimate dates. Here's another clarification. You'll find it on STOR page 93 through 94, and it involves what is a diagnostic staging procedure captured in that diagnostic staging procedure data item versus a surgical procedure. And it states, do not code excisional biopsies with clear or microscopic margins in the diagnostic staging procedure data item. Use the data item RX Summary Surgery 2023, NACER data item number 1291 to code these procedures. And then we are given the additional instruction, if a needle biopsy precedes an excisional biopsy or more extensive surgery, and upon the excisional biopsy or the more extensive surgery, the surgical margins are clear, do not consider the needle biopsy to be an excisional biopsy. So they've clarified some of the language that they use, but the concept is not brand new. So hopefully all of that makes sense. I just wanted to pull out a few highlights. And that is the information that I have for you on 2025 changes. And so I'm going to switch gears and talk about class of case. So give me just a moment to switch slides, and we will get started with the last presentation of the day. All right, you should now see clarifying class of case. Let's talk about that. My objectives are to discuss the differences between various categories of class of case, to describe the relationship between class of case and the date of first contact, and we're going to do some practice coding class of case using some practical examples so that you have good information to help you when it comes to coding class of case. And before I launch into that, I'm also going to put down in the chat the link to the evaluation for today's presentation. So please do fill out the evaluation. It does help greatly as we are preparing for next year's workshop. So I will put that down in the chat, and please feel free to fill that out. So I'm dropping that in the chat right now, and you should have it very shortly. And then I will start talking about class of case. All right. You should all be seeing the evaluation. Like I said, please do take some time to fill that out, or if you want to fill it out later, you can go ahead and copy that link and fill it out at your leisure. So let's start by defining class of case. And it's really the relationship between your facility and that patient. Stora puts it this way: class of case is assigned based on the nature of the involvement of the facility in the care of the patient. So really, class of case reflects that facility's role in managing the cancer and whether the cancer is required to be reported to the COC. And it also indicates whether the case was abstracted before or after the facility's reference date, because some of the non-analytic class of case categories have to do with cases that were reported before your reference date. We often receive multiple reports from different facilities. I mentioned that earlier because one hospital may have diagnosed the patient, and another hospital may have done part of the treatment, and a third hospital may have completed the treatment or done adjuvant treatment. And maybe a fourth hospital saw that patient as a consult for radiation. So class of case is important for us to be able to make appropriate decisions when we merge those records here at the state. We need to know what your facility actually did when it came to the diagnosis and or treatment of this patient. So what does STORE have to say about class of case and reportability? Well, an analytic case is defined this way. The American College of Surgeons Commission on Cancer requires registries and accredited programs to accession, abstract, and conduct follow-up activities for required tumors diagnosed and or initially treated at the abstracting facility. The tumors must meet the criteria for analytic cases, and pathologically and clinically diagnosed inpatients and outpatients must be included. And the ACR also requires analytic cases. That this year is found on the ACR supplements, page 63, if you're looking at that. And I've got a note on this slide for where you can find what we specifically require here in Arizona. What about non-analytic? The COC does not require registries and accredited programs to accession, abstract, or follow these cases, but the program and notice what I've highlighted here, central registry may require certain categories of non-analytic cases. And the ACR does require certain categories of non-analytic cases. You're going to find those in our supplements as well, and which non-analytic classes of case are required. So we often talk about data items being interrelated. Class of case and reportability are interrelated. What you assign as class of case may or may not determine whether that case is reportable to the state. I also wanted to define staff physician because some of the class of case categories talk about staff physicians. So how does STOR define staff physician? Well, the physician is not employed by the hospital, but the physician is under contract with the hospital and the physician has routine admitting privileges. That is considered to be a staff physician. And STOR page 87 says, when a hospital purchases a physician practice, that hospital needs to determine whether that practice is now legally considered part of the hospital and whether their activity is coded under the hospital's FIN number. So that can get confusing as well, but that is a staff physician for the purpose of class of case. So now let's break down class of case a little bit more specifically. Analytic classes of case, you guys know this. Class of case 00 through 22, that is an analytic case. That means that your facility was directly involved in either the patient's diagnosis or the first course of treatment or both. And again, those cases are always reportable to the ACR. Analytic cases are grouped based on the location of diagnosis and treatment, while non-analytic cases are grouped based on the reason the patient was seen at that facility. So if you're looking for a breakdown, if that patient was diagnosed at your facility, it's going to fall under either class of case 00 or one of the 10 ranges of codes, 10, 13, 14. You might have some of the staff physician codes in there as well. If your facility did not diagnose that patient, then you're going to be looking at the 20 range of codes because you gave treatment, but you may not have diagnosed them. We know that non-analytic cases have a class of case greater than or equal to 30, and you should assign the non-analytic class of case if your facility was not directly involved in either the patient's diagnosis or the first course of treatment or both. And it can be tricky. And when we talk about reportability, that gets complicated too, because the question is reportable to who? Who might require that case? Cases may be required by the Central Cancer Registry or the Commission on Cancer if you're a COC accredited facility, or your hospital might require those cases. And those non-analytic cases, like I said, may be abstracted to meet the Central Cancer Registry requirements, and we've detailed for you in our supplement what our requirements are, or because of a request by the facility's cancer program. That's why non-analytic cases might be collected in your registry database. So I worked for Mayo for quite a few years, and we collected GIST tumors, all GIST tumors, before they were nationally reportable because we had a physician request for those cases. So you may still have non-analytic cases that you are including in your registry's database. Basic concepts, I know, but it does get murky when it comes to class of case. So how do we determine our class of case? I like flowcharts, so I've given you guys my flowchart that I ask myself when I'm trying to determine what my class of case should be. So obviously analytic is easy. If your facility diagnosed and or provided first course of treatment, it's either analytic, you've answered yes, or non-analytic, which may be potentially reportable, as I've said. So how does that get complicated? Well, class of case 00 versus class of case 10. There is an important but subtle distinction between class of case 00 and class of case 10. Class of case 00 is coded if you know that they went elsewhere for treatment, but you don't know exactly where. And that means that it's on your facility to make sure that treatment was actually given elsewhere before you code to class of case 00. You code class of case 10 if that treatment was recommended, but you don't know if that patient ever received that treatment. And then obviously do your due diligence to find out if that treatment was given and update your abstracts appropriately. But make sure that you're coding 10 instead of 00 if you don't know for sure that that treatment was given. Otherwise, code to class of case 10. I'm not going to spend too much time here because you guys have a good understanding of analytic cases. Always code the more specific class of case over the NOS where possible. I've seen a lot of abstracts where that NOS code was given when really you do know that that was all the treatment that that patient had and that your facility gave all the treatment. So make sure that you are coding as specifically as you can if you know whether your facility gave part or all of that first course of treatment. And again, first course versus second course treatment is tricky. And sometimes cases get coded as analytic to the 10 or 20 range when the treatment was actually second course or subsequent treatment. And if your facility didn't provide first course of treatment, then that may make that a non-analytic case. So you've got to determine whether the treatment that your facility gave was first course or subsequent. All right. So here's my breakdown of analytic classes of case. And again, I'm going to go through this pretty quickly, but did your facility diagnose the patient? Yes. Then it's going to be either a class of case 00. If you didn't provide first course treatment and you don't know that that patient had first course treatment, or if you didn't provide first course treatment, but you know that they had first course treatment elsewhere, then you would use 10. If your facility provided part of first course treatment as well as diagnosing, that gets into a 13 or 14 or the staff physician codes, if the staff physician codes are applicable. If you didn't diagnose them, you're going to be looking at the 20 range of codes. And yes, I see folks making mistakes there as well. You shouldn't be coding a 20 range of codes if your facility diagnosed the patient. And then obviously we have all sorts of non-analytic cases. This is specified in our supplements as well, which ones of these non-analytic cases are reportable or not, and what our specifications are when it comes to reporting non-analytic classes of case. So make sure that you are aware of that. So I've broken down non-analytic cases for you and the questions that you can ask yourself to determine the most appropriate non-analytic class of case. Notice that class of case 30s may be reportable to us if that consult changes the histology or provides first histologic confirmation. That hasn't changed. We've always required class of case 30 if the facility changed the histology or provided the first histologic confirmation. Now let's talk about class of case 31. And I know this gets complicated too. In-transit care. What is in-transit care? I wanted to point out that a patient who continues to receive first course of treatment at your facility should be treated as analytic. You're actually giving part of first course of treatment. You need to carefully read the definition of in-transit care found in STOR, and you'll find that on page 74 to determine whether or not your facility just provided in-transit care. If they keep coming back and getting first course of treatment at your facility, that's not what in-transit care means. In-transit care is given to a patient who is temporarily away from that patient's usual practitioner for continuity of care. And so we got to be careful with that. STOR has definitions as well, and I've given you where to find them. Page 74, you need to go over those instructions and be coding your class of case appropriately. And then another reminder is that we are requiring class of case 32s. We used to have you submit a non-analytic tracking form to determine whether we wanted you to submit that class of case 32. We stopped doing that several years ago. Just send us class of case 32s. They are reportable to the ACR. And do not change your class of case based on whether or not we require that case. Code the class of case appropriately and send us the cases that meet our reportability guidelines. Determine what the most appropriate non-analytic class of case is and send us what we've asked for. What about autopsy? To code as classic case 38, that cancer should not have been suspected prior to the patient's death. Treatment should not be coded on these cases because if the patient is getting treated for cancer, then that is pretty likely that that cancer was diagnosed before that patient died. So just a few reminders. We've tried to make it as easy to follow as we can. I know it isn't always easy to follow. So ask when you need to. Use your resources, use the ACR supplements, ask us. What about patients that are not physically present at a facility? Well, those are your 40 ranges of codes. And I've given you some exceptions as well. I wanted to also point out that codes like 49 should never be coded under classic case. The ACR codes that. It's used by the Central Cancer Registry, not by hospitals. Same with classic case 99. We see a lot of cases that come in and the classic case has been coded 99. Do not use classic case 99. Per our supplements, that classic case is only to be used by the ACR. So just a little reminder there. Here's the pages that I was referencing, and you will find them in the 2025 manual, so I won't spend a whole lot of time there, but read through those supplements, read through those pages, determine what you are and are not able to code at the hospital level. And we appreciate that. We've got some clarifying notes too that will help when it comes to class case and reportability. So those slides that I've given you are based on this table here in our supplement. What about data first contact in classic case? And I'll wrap this up pretty quickly because I know we are almost out of time, but we do get a lot of questions about that. Again, I will refer you to STOR. If it's an analytic case, it's the date the patient qualifies as an analytic case. For non-analytic cases, the date of first contact is the date the patient's non-analytic status begins with respect to that cancer. So it follows logically. Like I said, if your classic case indicates that that patient was diagnosed at your facility, then that date of first contact should be the date of diagnosis. If that case was not diagnosed by you guys, but you provided treatment at your facility, then date of first contact should not equal date of diagnosis because you did not diagnose that patient. So there are some errors related to that as well that will pop up if you don't remember this, but it makes sense. It really is logical. So my next slide are what I like to call classic case buckets. You've got your 10 range, your cases that were diagnosed at your facility. You've got your 20 range, your cases that were given first course of treatment, but not diagnosed at your facility. And then you've got your non-analytic. And I've broken down for you how that relates to date of diagnosis. And I said it a little earlier, but there you have it in writing again to help when it comes to coding date of first contact. So I've got a couple of scenarios and I'll just take a couple of minutes. I haven't looked, but I don't think we have too many questions on these. So we can go over a little bit. Let's do a couple of practice scenarios and I will have you drop those into the chat just to keep it easy. And Michelle, if you wouldn't mind monitoring the chat to see what our consensus on answers are, that would be great. Presume the current diagnosis year. So here's one of the scenarios. A patient has an MRI of the pituitary gland at facility A. That MRI was concerning for microadenoma. The patient then follows up with Dr. Jones at facility B a couple of weeks later, and Dr. Jones at facility B says the MRI on October 31st demonstrates a pituitary adenoma and also states that the treatment will be surveillance with a repeat MRI ordered for 6 months in the future. How should the registrar from facility B code the classic case? And as a bonus, what's the date of diagnosis? So I'll give you maybe a minute or so to throw some answers in the chat with how you would code class of case in this scenario. All right. See at least one answer in there. Okay, now we're looking at facility B. Classic case 22. And the date of diagnosis is going to be October 31st. The physician is retrospectively confirming that that patient had a reportable diagnosis on 10/31. So the credit for diagnosing that patient still goes to facility A because facility A was where that patient was present when they were diagnosed and when that MRI was done. Now, the classic case here is going to be based on who made the treatment decision. And we need to remember that in this case, active surveillance is treatment. So the decision for active surveillance and for just doing a repeat MRI at 6 months intervals was made at facility B. So that is still analytic for facility B, but the diagnosis was made at facility A. And as far as we know, active surveillance is the entirety of first course of treatment, and that patient is going to continue to follow up with Dr. Jones. All right, here we go. We got a patient who's a winter visitor every November through April and also splits their time between South Dakota and Montana. They were diagnosed elsewhere in 2022 with a left upper lobe small cell lung cancer, and their systemic treatment was initiated elsewhere as well. They presented to and received in-transit care in February 2023 while they were visiting, but they completed treatment in South Dakota. There was a PET scan done, no overt evidence of persistent disease. Now they're presenting again in April of 2025 for a restaging surveillance PET CT at our Arizona facility, which shows new FDG avid left upper lobe pulmonary lesions, likely recurrent metastatic disease, and new left hilar and mediastinal lymphadenopathy. And the Arizona facility started them on systemic treatment for their recurrent disease, and then they go back to South Dakota in August. So think about what that classic case might be. I'm just going to give you a couple of seconds because I don't want to run over our time here. And I am seeing some good answers in the chat. 32. This is more than just in-transit care. This facility in Arizona did the whole workup for restaging, and they also initiated the subsequent treatment. It's a relationship that spans time, and it's not a true in-transit case where the patient was treated with the intent of them returning to their primary provider out of state. So I would code this to classic case 32. Patient was diagnosed with bladder cancer at facility A, and they had a TURBT at facility A prior to partial cystectomy given at facility B. And the path from their partial cystectomy showed no malignancy. What is the classic case at facility A? All right, I see some answers in there. I'll give you 10, 15 more seconds to throw in your answer. And well done. The classic case is going to be 13. So the TURBT gets a surgical code. It's coded as A270 under the RX Hosp Surgery 2023 field. And so that TURBT is considered to be partial first course of treatment. They still had the partial cystectomy elsewhere. So that is correct. I think I have another one. Patient is diagnosed with triple positive breast cancer, and they receive neoadjuvant chemo, immunotherapy, and a mastectomy with immediate implant reconstruction, along with adjuvant immunotherapy at facility A. And they then come to facility B for a risk-reducing hysterectomy with a bilateral salpingo-oophorectomy. So what's the classic case for facility B? And I'll just give us a couple of seconds to do that. Oh, I see a lot of classic case 21. And that is correct. Storr states that endocrine surgery includes procedures which suppress the naturally occurring hormonal activity of the patient and thus alter or affect the long-term control of the cancer's growth. And these procedures must be bilateral to qualify as endocrine surgery or radiation. If only one gland is intact at the start of treatment, then surgery to that remaining gland would qualify as endocrine treatment. So this would be standard of care and applicable because of the patient's ER/PR positive status. And I did mention that it was a bilateral salpingo-oophorectomy. So both sides were removed and they have to be for this to qualify as treatment. All right, last scenario, and I'll still give you back a couple of minutes of your day. Scenario 5. This patient was diagnosed at facility A with locally invasive left maxillary sinus squamous cell carcinoma, status post-subtotal resection in 2024. Well, almost a little over half a year later, they show up at facility B for restaging PET-CT, and PET shows findings in the left posterior maxillary nasopharyngeal region concerning for progression of malignancy and persistent activity in the superior maxillary regions with resolution of their neck nodes. No distant metastases. What's the classic case going to be for facility B? Okay, I'm seeing a couple of different answers there. And I would code this classic case to 30. And the reason for that is if you look, all facility B did was the restaging PET scan. They're not doing second course of treatment. They are specifically involved in what I would consider a consult for staging purposes. So that is why I would code to classic case 30 in this case. What I do notice is that everybody said that this was non-analytic and correct. So well done with that. And then it's just narrowing down to the specific classes of case. So I do see a question in the chat about classic case 30. Does it require evidence of disease? Classic case 30 can have evidence or can have no evidence of disease as well. Although if they have no evidence, classic case, well, actually, let me think through that before giving a specific answer on that. So I will include that in the Q&A document so that I can be very precise in my answer. So let's see, do we have any other real quick questions in the Q&A? All right, it looks like we have 2 questions. And again, while I'm flipping my screen to look at that, do remember, please, to fill out the evaluation or collect that link so that you can fill it out later as well. All right, Q&A, just real quick. Is classic case 20 acceptable if your facility didn't diagnose, but did provide some treatment? And for NCCN, there should be more treatment, but abstractor is unaware if additional treatment was actually given. Same principle there, I would say. Use the specific classic case codes if you know, but if you have to use those generic classic case codes, that's what they're there for. But the patient had already had treatment, so is it still staging workup? I would say that's the most appropriate classic case in that scenario because it's I mean, it's really restaging rather than a staging workup, but it's still a workup after treatment to determine if further treatment is necessary and to determine the patient's cancer burden at the conclusion of treatment. So restaging workup, yes, but it is non-analytic, and I would say that 30 is the most appropriate class of case for that scenario. So good questions, folks. And we really appreciate you being here for the conclusion of our workshop. Hopefully you're taking away some good information. Like I said, please fill out those evaluations and let us know your thoughts as we begin to plan for next year's workshop. And thank you again for your time. Have a lovely rest of your day.